No problem.
Okay, excellent. So with that, I guess if you guys could introduce yourselves a little bit, talk a little bit about CPC Plus. Just so you know, we have just, CPC Plus has just accepted Nebraska as a region, and we are trying to decide if we are all going to go in and try and become CPC Plus clinics, or if some of us are or not. We're still in that learning stage. So with that, I'll turn it over to you, Scott.
Fantastic. Thank you again, Jolene, and good afternoon to all of my comrade in arms out there in Nebraska. I send you greetings from the beautiful Smoky Mountains of East Tennessee, and I apologize in advance for my accent, so hopefully we'll be able to get through that. I'm the Director of Operations for the Value-Based Care Division, which is part of Summit Strategic Solutions. And basically, Summit Strategic Solutions is a MSO that supports medical groups moving from fee-for-service environments to value-based care environments. And Summit Strategic Solutions was actually formed from a 400-provider large primary care group called Summit Medical Group. So a lot of times throughout the presentation, you'll hear me refer to we as we conquer the CPC Plus 4 that we're in. And so we is Summit Medical Group operations and physicians, and Summit Strategic Solutions subject matter expertise and project management. So I just want to make sure I kind of distinguish between the two groups. So with me today I have Melissa Pritchard, and she is from our development department. And Melissa did a fantastic job helping me put my slides together because I'm a CPA and I'm not that creative, but I love to read regulations and apply them to daily operations, which is right up my alley with CPC Plus. So we'll go ahead and what we'll do is we will I'll try to ask her questions as we go along, if that's okay, Jolene, and that way, and if I missed you, there's going to be an opportunity at the end of the presentation for questions.
Okay, that would be great. Thank you.
All right, so basically today what we're going to talk about, there's 5 areas that are 5 items we're going to discuss today with CPC Plus to make sure we're all on the same page. And that's just a quick introduction to the program. Jolene asked me to also talk about reporting. She asked me to touch base on return on investment, staffing, and the application process. So the goal is at the end of the presentation, you'll have enough information to decide whether you want to embark in this adventure or not. So in terms of introduction, those of you all are probably familiar with the overall purpose of CPC Plus. I consider CPC Plus a program that transforms practices one by one, and when I say practice, I mean the brick and mortar, the actual practice address. And by transforming the operations and the way that primary care is delivered, CPC Plus hopes to strengthen primary care across the country, promote health, reduce healthcare costs, and so forth. So the main item I want to get across today is that all the activities we're going to discuss have to happen at the practice address or practice site. And that was one challenge that Summit Medical Group had because we are such a large organization. A lot of these activities would be managed and executed through central or corporate staff going out to the sites and kind of spoon feeding, if you will, information to the site managers. So, so we've had to adapt to that and make sure that we have a process in place where the site managers are just as educated as we are so that they can complete the various tasks required by CPC Plus. As Jolene had alluded to earlier, there are 4 states now that have a round 2 opportunity for CPC Plus, and as you all know, Nebraska is one of them, and those states are highlighted in the dark blue. The first round of CPC Plus sites, there's 2,891 practice addresses that are currently in CPC Plus. 2% of those practices are located in the state of Tennessee. There's about 56. And of those 56, 14 practice sites are part of Summit Medical Group. And both myself and Melissa have had the opportunity to partner with Summit in embarking on the CPC Plus journey, as I've mentioned. So digging deeper into the program, I like to compare CPC Plus to the NCQA patient-centered medical home process. And I believe, Jolene, you all are PCMH certified. Is that correct?
We are PCMH certified through the state of Nebraska, not through NCQA.
Okay, perfect. Okay, so at the end of the day, I've learned, and Jolene, you probably would agree with this, I would think, that most patient-centered medical home initiatives or programs, whether they're state or national, have a lot of the same functions and features and goals. Would that be a fair statement, Jolene?
Yes, I think so.
Yeah. So CPC Plus is similar to at least the national PCMH program. And in fact, we just attended the NCQA conference for the 2017 regulations for PCMH, and there were a number of references made to CPC Plus. CPC Plus basically came from the NCQA PCMH programs. So there's 5 functions within PCMH, and just like with NCQA, I'm assuming with your state, Jolene, there are probably functions of the program. And they focus on access and continuity, data-driven health management of a given population. Another function is care management and engaging the patient and caregiver. Again, care management, care coordination would make up the 5 functions of CPC Plus. With the program, there's basically 2 tracks that a site can apply for, and the differences are they're called Track 1 and Track 2. The differences are basically that Track 2 is more is further reaching in the transformational activities, which we'll get into here in just a second. The Track 1 it still has transformation, but not to the extent as Track 2. With that being said, Track 2, there's more monies available for the practice address with that particular track. So more responsibilities, more money, which is similar to other programs that we've seen. So basically, we have the 5 functions, and what happens with CPC Plus is if you're looking at the structure of the program, it starts with the 5 functions, and then each function has transformational activities, and we're not going to go through each one of these, but I look at it as having the function. Each one of these items you'll see here on the next slide for access and continuity are a transformational goal, and then each goal has activities, and I'll give you a couple examples of that here in a second. That you'll see on this slide with access and continuity, the bottom arrow, and a lot of times here at Summit we refer to these slides as the arrows, because these arrows are really guides for how we transform our practice and how we meet our contractual obligation with CMS. Matter of fact, I took every one of these arrows and I footed them to the practice agreement that each one of our 14 sites had to sign. So as I interact with my physicians and explain what our goals are, I always focus on these arrows because I know it ties to the contract. So you'll see so the first slide is the access and continuity. And as I mentioned, each one of these arrows equals a goal. The first arrow is a common transformational goal of a lot of different programs. I don't know, Jolene, if the state of Nebraska has this, but the state of Tennessee has a patient-centered medical home program also that focuses on 24/7 access to a provider that has real-time access to EMR. Also, the NCQA patient-centered medical home program also has that same transformational goal. So what I'm learning as I embark in this is a lot of different programs end up having the same transformational goals. So here's the arrows for access and continuity. Again, I won't read all these slides to you, but you at least will get a feel for the timeline that you would have to maintain and apply it to which track and which transformational goal would be applicable to you depending on what track that you land in. This slide, the patient and care engagement, the patient and caregiver engagement, I wanted to illustrate the structure of CPC Plus with the second arrow that you see on this slide. As I mentioned earlier, you have the 5 functions. So in this case, the functions patient and caregiver engagement. And then the transformational goal, which is the second arrow. The transformational goal would be having a plan, if you're at track 1, to have a plan for using self-management tools in your practice. And then there are activities tied to each one of these goals. And so, and CMS will gives us lots of choices of what activities we want to engage in. But a good activity that would meet this particular goal would be using blood pressure logs or sugar logs. If your sites already use those kind of tools to have the patients record their measurements at home and then bringing those logs into the practice, that activity would meet this particular transformational goal of having a plan or process for self-management tools in your sites. Are there any questions about the structure of CPC Plus as I flip through?
Scott, I think if you opened your chat box, there might be a couple questions there. One is, where can these be found?
So, good question. And what I'll do, Joey, if you don't mind, because I can't see the chat box on my screen, so maybe we'll stop for a second and I'll have you read the questions and I'll answer them. Is that okay?
That would be fine.
So this information actually is in an implementation guide for CPC Plus Track 1 sites. And so I failed to mention earlier that Summit Medical Group, all 14 of their sites are Track 1. And so as we embark in CPC Plus, I will make the comment that I was a bit skeptical just because I've worked with CMS before. I'm sure y'all have as well. But I really believe with this program, CMS has gone above and beyond giving us the tools that we need to be successful. And so these arrows are part of the implementation guide that they gave us. And now CMS didn't tell us each one of these transformational goals tied to the practice agreement. With me being a CPA, I just was OCD and wanted to make sure that these arrows tie to our contractual obligations. They didn't go that far, but they did give us these goals to use. And I do like the timeline. If you look at the top of the care management slide, it gives you different tasks to complete by quarter. But on the fourth quarter, you'll see basically that's the goal that's listed in our provider agreement.
Okay, and so that we can download off the internet? Got it. Okay, okay, we got it. And then two other questions is, for the 24/7, do we have to have that be a provider within our own clinic, or can it be some other provider outside of our clinic?
Good question. So, so what you'll find with CPC Plus is they will give you very high-level answers. So, so I try to follow their scheme. A couple questions, though. When you say outside your practice, are you referring to a provider who is employed or bills under a tax ID other than SERPA's?
Yes.
Or are they? Okay.
Or so, other than the clinic that would be applying, yes.
Okay. So with one more question. So with SERPA, are all your practice addresses all under one tax ID, or are they multiple tax IDs?
Multiple tax IDs, so each clinic will need to apply themselves.
Gotcha. Okay. So, so the answer would be that CPC Plus would not have a preference. They're not going to go into a lot of detail saying here's how you have to do it, but they will say at the end of the day, one transformational goal is that 24/7 a patient has access to make a phone call to a provider who will be in front of the EMR and able to take that patient's call and answer the questions with the EMR in front of them.
So if that practitioner is sitting like they're a hospitalist in the hospital and they have access to your EMR, that would be acceptable is what I'm hearing you say.
Yeah, the one challenge that we've had, and there's other CPC Plus practices that I've dealt with across the country, there's an attempt to meet this transformational goal by saying, well, the provider has access, the provider is at home and has a VPN to their house. And so at their house, they access the EMR through VPN. But the challenge is that on Wednesday nights, the provider who's on call goes to church or maybe they're out at the grocery store, or maybe they're going to a football game. And so if they're gone from that home for an extended amount of time, CMS has come back and said, well, that's really not access to a provider 24/7 who actually has the EMR in front of them. So the reason I share that is to say if we go down the road of using the hospitalist to take the call, we would have to have internal controls in place to make sure that the hospitalist is actually looking at the EMR. There's a difference, as you all know, between having access and then using it. And so as long as the hospitalist is actually utilizing the EMR when they're talking to, when he or she are talking to the patient, you'll be in good shape.
Okay. And then, will that implementation guide that you were talking about, does that come after you apply, or is that, or when do you get the actual implementation guide?
One of the thrills I've had in my experience with CPC Plus is that when our 14 sites got accepted, CMS was actually building these materials at the same time that the first round of sites were going through the process. So to answer your question, I'd have to go look and see on the CMS website. Some of this information might be available on the CMS website. The majority of it, though, is located in a CPC Plus portal, which we'll talk about here later, that you will get access to once you become a CPC Plus site. So there might be a couple of these items that might be on CMS's website, but the majority of it I've gotten from my CPC Plus portal.
Okay, thank you.
So finished with the introduction of CPC Plus. So one topic that Jolene wanted me to talk about was reporting. And so there's lots and lots of reporting that goes on with CPC Plus. Keep in mind that all the reporting is at the site level. Jolene let you know too, with Summit Medical Group, one challenge we had was that all of the, we have 54 addresses, and all of them are under one tax ID. And so it was a paradigm change for our organization to go back and say, well, gosh, we still have to have an application by practice address. It's still a little bit of a challenge for us, to be quite frank. So it sounds like you all already have the game in knowing that basically everything that we do in CPC Plus is going to be at the practice address level, which includes reporting. So there's transformational reporting, and we'll go into do a deep dive into each one of these here in a second. But the transformational reporting is quarterly. Then there's quality and utilization reporting that's quarterly and annually. There's financial reporting that's annual. And then there's provider rosters, which will make more sense as we get into the detail. And then also there's regional CPC Plus reporting. And so because we're in Tennessee, we're in the Tennessee region. And so I interact with both my CPC Plus regional experts as well as my CMS level experts as well. So in terms of the transformational reporting, what happens is, first off, when we become a CPC Plus site, we will sign our contract and that will be sent off to CMS. Then we go through the process of applying for access to the CPC Plus portal. And each practice address has its own individual portal. Myself and my department have to gather data from 14 individual portals. Because you all will also be applying a practice address, you'll have multiple portals because each portal only has data for that particular practice address. So what we've learned is that we have corporate or central users, which would be myself and a couple of folks in my department. We also have site-level users as well, like the site manager, and maybe she has a backup, so that we have multiple folks who can get into these portals because the majority of our reporting goes to the portals. And if we miss a deadline, you're naughty, and it's a little bit of a challenge to kind of recoup from that. So it's really important to have multiple users. Matter of fact, you time out after 60 days if you've not logged into the portal. So keep that in mind. So what happens is basically at the end of each quarter, the last week of each quarter, for about a 3-week period, is the report submission time frame in which we have to report our progress on achieving those transformational goals or the arrows that we looked at earlier. And so the best practice that we have found is that we bring our site managers on to the central office, and I have a hard copy of the survey, and we fill it out together because it's keep in mind, like, we've done so much of this level, I'm having to kind of educate my site managers on what we're actually doing with CPC Plus. So it helps to bring them in and complete the survey hard copy first, and then go into the portal and complete the survey electronically. And my other piece of advice is to start early, because if you miss the deadline, it's a challenge to get an exception, and payments can be held up.
Oh, I just did that. Hold on, Scott. You might be. Let's see. Yeah. Scott, audio. You're unmuted.
Since he's the host, I think he's trying to tell you to dial in. Is that what he was?
I think you dropped.
Yeah, I think you dropped, so.
I think it's on, when you put it on your phone, you
I
can
think
turn
if
your phone on and you can
you
hear it.
dialed in that number from your little deal.
Yeah, so that I could see the chat boxes.
Yep.
And, okay. So what do you think I need to do, guys?
I think if
Can you hear us?
We can hear you, Jolene.
Okay. Hold on. Scott Meyer, can you hear me? I'm going to make you the presenter again. Let's see. Make organizer.
Hello, this is Scott.
Oh, Scott, are you there?
Hey, I'm here.
Okay. Sorry, I did that, so I apologize. So.
I just thought that you didn't like what I had to say.
Oh, I was trying to. I tried to log in on two different places and it messed everything up, so I apologize. So.
It's no problem at all. So at any rate, so again, I think I've illustrated the importance of the transformational reporting. It's a really super big deal to get it done timely. So the next slide, what I thought I would do is give you just a couple of examples of questions that are on these surveys. The first example is if you're a Track 1 site, this is just an example of the kind of question they're going to ask. They're going to get into the details of your ADT feed. So I'm not sure how SERPA is organized, but you know, for Summit Medical Group and Summit Strategic Solutions, we have a department of care coordinators who reach out to patients who've been discharged from the hospital within 3 days of, or within 2 days of discharge, and I think 2 days from ED visits as well. So ADT feeds are paramount in that process. If we don't have them, then obviously it's hard to meet that goal. So CPC Plus has a whole care management function and care coordination, and so they're going to ask questions about the finite details of how each one of your sites are going to expedite care management. And so, and this is just the bottom part of that question. So we'll just want to know the timeline of how often do you get to your hospitals. We actually had to list each one of the hospitals that we get ADT feeds, the frequency, and any kind of backup people that we would call at the hospital if the ADT feeds weren't working.
Was this
another
I'm
sorry?
Was this in the application, or was this after you were accepted that you had to answer these questions?
This is after been accepted. So once this is out, we're going to pretend that we've already been accepted, and we're moving down the path of how to function in this program.
Okay.
So yeah, so these are questions that we have to answer each quarter. And so in the next slide, you'll see at the top, this is a Track 2 question, and behavioral health is a big piece of CPC Plus. I'm assuming with the Nebraska Patient Centered Medical Home, behavioral health is probably a piece of that as well. Most, I know the Tennessee PCMH program, behavioral health is a big deal. So, so again, you see these recurrent themes throughout the various programs. And so if you notice at the top, it talks about the behavioral health, and then gives you the title, and then right below that it shows you the reporting periods. And so to your point, Jolene, that we're not necessarily always answering each one of these questions, but if I'm a Track 2 site, I'm going to have to answer this question in quarters 2 and quarters 4. So in addition to transformational reporting, there's quality and utilization reporting, which are probably similar to any value-based care contracts you have currently or your PQRS program. The quality piece of CPC Plus is similar. There's basically two parts to quality, and there's the quality measures, which are all reported through ECQMs, your little ECQM, and then the second piece is patient satisfaction, and again, this would be similar to your PQRS reporting. So basically, the one lesson that we had to learn at Summit Medical Group is that ECQMs are the only way to report the quality measures. Before, at Summit Medical Group, we used the GPRO process for reporting our PQRS measures each year. And I don't know if how you all currently report your PQRS, but we do it at the tax ID level through GPRO. So having to go through and work with our EMR to get the ECQMs to actually work has been a bit of a challenge for us. So at the end of the day, we're required to report 9 of the 14 measures. We're reporting all 14. We're going to submit the reports for just 9 of them. So that we're trying to get the functionality up and going to where we can report all 14 ECQMs and then pick our best 9. And then we will submit those to CMS either in January or February 2018. So there's 2 options for reporting through ECQMs. You can use the attestation, which again, you sign the attestation, obviously you submit it through. You just have to make sure you have the ECQM report that's backup as evidence, because most likely you'll be audited. And I know some medical group, with us having so many sites, we're expecting to be audited. So we can do the attestation, or we can do the EMR download through the QRSA-3 file. So that's on an annual basis. But recently we just learned, and I mentioned earlier, the round 1 sites we're learning the program, but so is CPC Plus. And just 2 or 3 weeks ago, we were told by CPC Plus that now quarterly we have to report our progress in meeting transformational goals and changing our processes to improve our performance on 3 ECQMs. So going forward is now we have the annual reporting, and then we have the quarterly reporting, which will most likely be a part of that transformational survey we talked about earlier. So the best practice to take away is to report on all 14 ECQMs and then try to submit the 9 best performance, ECQMs that you're performing best on. And another piece of advice I would give you all is, as you're going through the application process, I would go ahead now and confirm with your vendor that you all have the functionality to report ECQMs, because that's something that we did not do. And then once we got in the program, we were scrambling trying to get that functionality to work.
Did you have to submit a letter from your vendor that they could do that?
Yeah, the letter really focuses on whether you're Cert 4 or Cert 15. The language of the EMR has to be either 14 or 15 certified. So our letter did not go into depth on the ECQM piece. And I think that was just a bit of a challenge, because we're 14 cert, that the ECQM functionality had never been engaged at Summit, and rightly so, because we always reported our quality measures through that GPRO web interface. So there was really never a need to use the ECQM, if that makes sense. So, how do you all report your PQRS measures?
We report it through GPRO
As a group.
Okay.
And so now we won't do that. Or we'll do that on top of this. We'll be doing
so that's a great question, Jolene. So what we learned is, in our pool of Medicare patients, there's the traditional Medicare patients, which we in Tennessee call them our CAHABA patients, because CAHABA is the General Benefits Administrator for our traditional Medicare patients. And then we kind of have everybody else, right? So within that CAHABA, or that traditional Medicare pool of patients from 14 of the addresses will be reported through these ECQMs through the attestation process. So the other 40 practices that have CAHABA patients will continue to have their quality measures reported through GPRO. And we all know that PQRS is gone and now it's MIPS. At the end of the day, I have found that the measures are about the same between PQRS and MIPS, right? So again, for our sites, we have 54 sites. We have 14 that are CPC Plus. Those 14 CPC Plus sites, their quality measures will go through ECQMs, and then the other 40 will continue to go through GPRO as we always have done. Does that help?
I think so. So we won't be reporting GPRO for everybody. It'll just be the ones that are not CPC Plus.
Exactly. Exactly right. So, okay.
Yeah,
So moving on.
Are they an ACO?
You guys are an ACO, right? Summit?
We are not an ACO. We are not.
So I think
Their Summit Strategic Solutions was a ACO at one time, and then opted out.
And so yeah, with us being an ACO, we're having the discussion of that we will still need to report for GPRO for the whole ACO, and then the clinics that are CPC Plus will have to report their 9, the 14 or whatever, EC or the
That's right.
ECQM.
Yes, and that rings true to what I've read, Jolene. And again, we're not an ACO, but what I've read about ACOs is that the CPC Plus reporting does not supersede whatever reporting the ACO has to do.
Okay.
So I believe you're right, and if you want, I'll make a note to make sure I send you some resources on that. I just read that the other day.
Okay.
And thought about you.
Oh, the other question that I have is on the patient satisfaction. As an ACO, we do one large HCAHPS, patient satisfaction, the clinic and group. But do each of your clinics do their own clinic and group HCAHPS survey for this?
So each practice site will have its own CAHPS completed for CPC Plus.
Okay.
And so, and keep in mind that the structure of Summit Medical Group is it's one great big tax ID.
Right.
So what will happen is basically we're carving out the patients from that tax ID to 14 addresses that are CPC Plus. They just kind of come out of that. But what's left, it's kind of business as usual for what's left. We would still do the regular GPRO reporting. We use Press Ganey for our CAHPS reporting each year, patient satisfaction reporting. That will continue.
Okay. Thank you.
Welcome. You're welcome. So what I thought I would do is just briefly, not the super detail, but just give you an idea of what the 14 ECQMs are, the quality measures. So they're organized into 3 groups. The first group are outcome measures. And again, my advice is to try to report on as many as you possibly can and then pick the 9 best. So, but most likely you're probably reporting on some of these already. So here's the outcome measures. Then group 2 is the complex care measures. And I believe one of them, the cognitive assessment, or the fall screening is part of with PQRS for us last year. So you'll see some of these measures are consistent with PQRS MIPS. And I'm not familiar with the ACO reporting, but these might be similar as you look at them. And the third group is the catch-all group is what I call it. So, and again, you get to pick a certain amount of each one of these. So then, in addition to the quality measures, as I mentioned, the second piece is patient experience, which Jolene already touched on. CMS will conduct the CAHPS surveys on our behalf, and we don't have a lot more detail on that right now, what that looks like. What we've been told is that CMS will initiate that for us. The trigger for the initiation of the surveys is for each one of our sites to load in a patient roster into our portal. And keep in mind that portal is basically the conduit, if you will, for communication back and forth between the practice and CMS. So once we load that patient roster into the portal, it will tee up CMS to generate the CAHPS surveys on our behalf. And again, the best practice that we've learned is that we here at Summit conduct our own patient satisfaction surveys through a group called Survey Vitals. So, and again, we use Press Ganey for the CAPS, but we take information from our Survey Vitals reports and we use those to identify quality improvement opportunities. So that served us very well here at Summit Medical Group to have that practice in place. So in addition to quality, we have utilization, which is pretty standard for any kind of value-based contracts you have. What will happen is CMS will calculate from claims data a certain ratio of inpatient admissions and emergency department visits. And I'm sure you all have care coordination and care management functions in place since you're an ACO, and we have learned that our care coordination efforts have truly impacted our expenses and our utilization, which I'm sure you all have on your side as well. So moving on from the quality reporting to financial reporting, and so what will happen is, again, this is obviously after you've been accepted into CPC Plus, there are 2 annual reports that your controller or CFO will most likely generate. The first one will be due at the end of each performance year, and it will be a forecast of how you're going to use all these monies coming in from CMS to transform your practice. And so there's a forecasting, if you will. And so at the end of the year, you forecast next year, and then in the February of the subsequent year, we are going to fill out kind of like a cost report, where we go back and say, here's how we used all the money for the prior year. So there's always a forecasting, and then there's always a cost reporting piece, if you will. And so that happens each year. That reporting will go through the portal also. And right now, CMS has not published yet the cost report and what it will look like, but I'm sure they will publish it here in the next month, and then we'll get a feel here on how that report should look. But I'm guessing the cost reporting will be similar to how a cost report is done for a hospital or perhaps a rural health clinic if you all have rural health clinics. So there are a number of pieces that are tied to the financial reporting, and I thought the best place would be to kind of lump it here in the financial report section. So one list that you would use frequently is called a quarterly attribution list, and this list will detail out all the patients that CMS will be paying each one of your sites a monthly care management fee, as well as a bonus incentive, and we'll go into a lot more detail on what those monies look like here in a second. But the main thing is that with CPC Plus, the attribution lists are formed by CMS, and CMS will go out and they will look over a 24-month period, a look-back period, and they'll determine which PCP provided the plurality of care through E&M codes to a particular patient, and whichever PCP had the most office visits, if you will, that patient gets attributed to that PCP for that quarter. So every quarter, the look-back period changes, and I have another slide here that will kind of illustrate that here in a second. Another piece that goes into the attribution list is obviously CMS has to identify eligible patients. So only traditional Medicare patients that have Medicare, traditional Medicare as primary payer would be eligible for CPC Plus. If the patient is institutionalized in long-term care, if they're incarcerated, grandma knocked off a bank somewhere, they're not eligible either to be a part of the CPC Plus attribution list. So if the patient is a hospice patient or ESRD, and then obviously if they're part of the shared savings program other than the ACO, those patients will not be eligible to be on the list. So the way the look-back period works is, so I thought a lot of this, again, came from the CPC Plus manuals that we use, but if you look at 2017 on this slide, and CMS is going to go back and say, we want to come up with the attribution list for Q1 of 2017, what they do is they look at the first previous quarter, which in this case would be Q4 2016, and identify all the eligible patients. Then they will go back to the previous quarters and identify in those previous quarters who gave the plurality of care to those eligible patients. So I've had a lot of physicians I've had to explain that to, because what happens is, let's say they have a new patient that starts in February of 2017, which would be obviously Q1, and that patient is not on the attribution list. Well, that's because the patient's a new patient and some other PCP somewhere provided the priority of care during the look-back period, and therefore that patient will not appear on the attribution list for Q1 of 2017. Now, eventually, over time, that patient will, obviously, as long as they continue to come to your practice. But that's been a challenge of trying to explain to providers, you have new patients that won't appear on your attribution list for a while. On the same token, there's been some patients who appear on the attribution list who we know have moved out of state, or they have gone to another PCP. Those patients will still appear on the attribution list, but and they will fall off eventually once that patient establishes a PCP relationship elsewhere. And so the way I kind of look at it is it's a wash. We're providing care for patients, new patients that we're not getting monies for, but in the same token, we're still getting paid monies for patients that really have left the practice, and so you kind of, it's a wash. That's the only way I know how to explain it, Jolene. So the next slide just gives you a feel for what the look-back periods are for each quarter of 2017. Again, you'll get this material when you've accepted a CPC Plus, so look at that diagram. But it basically shows each quarter, the attribution quarter, what months are part of the look-back period. So basically, the reason that the attribution list is important because all the patients appear on that list, and then there's an assigned care management fee. And again, these lists come out quarterly, so there is a care management fee that CMS pays us, and that money is used to achieve these transformational goals. So the purpose of the care management fee is to support basically augmented staffing and training. And in your CPC Plus agreement, there's a list of allowed expenses that we can use the CMS for, and then there's a list of not allowed expenses. And basically, the allowed expenses are staffing and some training. Any kind of IT, if you're a Track 1 site, if you want to purchase a higher level IT product, that's not allowed. Paying for billing staff, accounting staff, support staff who really are not completing CPC Plus activities at the front line, those expenses will not be allowed to be covered by the care management fee. So again, the point of it is CMS giving us monies to transform our practices for all patients, and that was a paradigm change for Summit. We were thinking that we were getting this care management fee to transform care for our traditional Medicare patients, and that's not the case. We're getting a care management fee to expedite these CPC Plus activities for all patients in our practices, regardless of what payer they have. So what happens is when the patients appear on the attribution list, CMS will assign a tier. For Track 1, there's 4 tiers, and for Track 2 sites, there's 5 tiers. Each tier has a monthly care management fee, which the next slide should illustrate. You'll see you'll see the 4 tiers. There's 5 tiers on the left-hand side. The 5th tier is for Track 2 only, and then you'll see the dollar amount tied to each tier. And the assignment of the tier is not just being on the attribution list. Once you qualify for the attribution list, then CMS goes back and looks at your HCC coding efforts. And so if your sites are paying attention and using the diagnosis codes that best represent the burden of the disease, then your patients will most likely be an appropriate tier. I've encountered some physicians, though, that maybe did not pay very close attention to their HCC coding, right? And so they were thinking that their patients would be in a more expensive tier, if you will, because they were sicker patients, but because they had not paid attention to their HCC coding, those patients appeared in a lower tier. So in order to identify your care management fee, the patient has to be on the attribution list, they have to be eligible, they have to be assigned to it, then CMS assigns a tier based on HCC coding. So again, Jolene asked for lessons learned. So one lesson I learned was to already have available to me this slide that explains to my providers that the assignment to the tiers, the HCC coding for attribution list for a given month. In this example, the red box, you'll see the months of January to June 2017, or Q1 and Q2 2017. The HCC coding used to determine the tier came from the calendar year of 2015. And so I had some providers, again, who maybe did not pay the close attention to their HCC coding in 2015 tier. But then you'll see over the course of time, the HCC coding efforts will be more timely and more tied to the attribution reports. The time periods will be similar. So we talked about the care management fee. The next financial piece that we have to consider in financial reporting is a performance-based incentive payment. And the good news is that there's no...
Scott, this is Jolene. I have a couple questions here. One is, does the care management fee, is that a fee that will ever have to be paid back? Is that at risk?
That's a wonderful question, and I'm very confident in saying no. You will not have to, because I have it in writing. I'll send it to you, Jolene, because I have dug for that source document, and I have it. So, and it seems weird, doesn't it? Because at the end of the day, we have to do financial projections, and we have to do cost reports showing how we use that care management fee. But at the end of the day, if we're not using all the care management fee that we were given in a particular year, let's say in 2017 we were given $1 million, and we only used $800,000 of that million on staffing, that $200,000 difference would not have to be returned. It would just stay in your checkbook and would be used in a subsequent year. So although we have to have pretty stringent reporting, at the end of the day, we don't have to return it if we don't use it. Now that is not the case with the bonus that we're going to talk about.
Okay, and is there limitations on what that care management fee can be spent on?
Yes, limitations would be, there's a list in your contract that you'll sign with CMS. There's a list of allowed expenses, which is basically, at the end of the day, it's going to be salaries and wages and benefits for those employees who are conducting CPC Plus activities. And that's, in a nutshell, basically it, in addition to some training. Then there's a list of prohibited expenses, and there's a long list, and some examples of that would be IT purchases, if there's any kind of EMR and upgrades you wanted to use. You can't use the CMS monies to cover that. We at Summit Medical Group thought that we'd be able to use the CMS to pay for a risk stratification software. And have been told multiple times from CMS that we can't do that, although risk stratification is a requirement of the program, and they do give you some tools that you can use. But at the end of the day, there's no IT purchases. There's physician compensation would not be a part of the use of CMS unless the physician is conducting CPC Plus activities, which if you think about it, they are, right? Again, that they're very, CMS is very defined in how those monies can be used. Now, I will make a comment that with Track 2 sites, there's a little bit more leeway because the transformational goals are much more stringent than Track 1 site. So with the Track 2 site, there is a little bit of money that can be used for IT, information technology upgrades. So with the Track 1 site, you cannot.
Okay, thank you. The other question is for the HCC, the different tiers, will the clinics be able to see that somewhere prior to the application, or is that after the application is accepted?
That is an excellent question. That means you're paying attention, and I love it. You will not be able to see that prior to.
Okay, so it's after.
That's
okay.
It's a very excellent question. It was something that I struggled with trying to figure out, can I even project this? And it was a challenge. I will make the comment here at Summit, we we have a wonderful risk department of, we have coders that work in our central office that do pre-visit planning where they look at the medical record and they look at all the source documents, and then they send messages to the provider saying, hey, you might want to think about using diabetes with neuropathy instead of just general diabetes because of all the supporting documentation. And that is a wonderful, wonderful tool that has served our physicians very well. The challenge is that mostly that attention to HCC coding was paid to for certain value-based contracts. So our traditional Medicare patients, some of the providers, although we had instructed them, make sure you do this for everybody, some of the providers really just focused on HCC coding for some payers. And so that's where the shock was, if you will, because they were surprised. Providers knew that they had sicker patients, but again, they used the diabetes general diagnosis code instead of diabetes with neuropathy, and therefore Medicare doesn't realize that the patient's sicker than what they really are.
Yeah.
Does that help?
We have another question here, Scott.
I understood there was a couple of slides ago where it talked about that a particular reporting period is actually based on going back, to reporting periods prior to that, and that the risk scoring has already been done. All right. So when we talk about improving our coders and our providers' risk scoring, did you and your group have sort of when you made the decision that you wanted to apply and go, that you committed to some of that training, in a more immediate fashion so that you begin to be developing a better profile, or how did you do that?
That's an excellent question. Matter of fact, we are embarking on our annual HCC coding education, which is mandatory for all of we have 400 providers. We have about 200 physicians and 200 mid-level providers. But in order to be a part of Summit Medical Group, each physician is required to go through a 4-hour training each year on HCC coding. And we get them steak dinners and you make it super nice for them, but everyone has to go through that training. And I would say that that's really the first step, is explain. A lot of physicians just don't know. Honestly, at the end of the day, that they don't know. I mean, they know that their patient has diabetes with neuropathy, but they probably have just not been engaged in the physician billing piece. And so whatever diagnosis code kind of got the claim through the door, and it didn't matter. And so that training, understanding that basically we have to start now to build a case with CMS to show them that the burden that the disease that this patient has warrants higher utilization of the healthcare system. And if we don't, we not only set ourselves up for not being as successful as we could be with CPC Plus, but then we really limit ourselves for being an attractive partner for insurance plans who want to have that value-based contract. So to answer your question, we definitely do the mandatory training, and then my staff, I adore all of my staff, but my risk adjusting coders have a special place in my heart because they've all had to learn not just the procedural coding, but they really have to learn how to look at the entire medical record and look at consult notes and ancillary test results, and looking to see what burden of this disease really is represented in the documentation, and then spending time educating the provider, saying, here's the diagnosis codes that we think would best represent the disease burden. Physician, you have to bless it and say yes, but that process alone has skyrocketed or not, I guess skyrocket is not the right word, has made our risk scores much more reflective of what is actually in the medical record.
And I will tell you, Jolene, this is Melissa from Business Development. The risk score, just to kind of give a little specificity to that. So our risk adjustment factor has went up 0.128 in the last 2 years, which really results in tens of millions of dollars to the medical service pool. So when you're looking at, and I know we've been working with each other and Kim and Jack on a couple different opportunities with you all, when you're thinking through that stuff, the coding support and our risk adjustment team, like Scott said, they are stellar. They really are a really knowledgeable subject matter experts in this area, and this is what, to be real honest, and I'm sure you all know this, this is the sexy part right now, because this is the piece the health plans like, the providers are liking, everybody that's involved with fee-for-service moving to value-based care is on this piece of it, because it makes a big difference. So just remember that, that's another piece that Summit can provide you. So.
Okay, thank
To
you.
your point, it's definitely an investment, because if you look at the spot I have in front, you'll see if we weren't paying attention to HCCs in 2015, it's impacting our care management fees in 2017. So it's definitely, we invest now knowing that in the future will be the payoff.
As long as they don't change the rules.
Well, that is true. It's true. I'm not going to argue that. Sounds like you've been around the block a few times, like the rest of us. So that's why I refer to you all as my comrade in arms, because I feel your pain. I'm there with you.
Okay. We have another question here. We have one more question.
So you had mentioned the restrictions on payments and how compensation, can't be used for compensation for physicians. For all of our practices, that are a part of SERPA, they're all independent. So they're owned by a group or a selection of individuals, generally physicians. So if there's any money, given your example that there's $1 million that come in and there's $200,000 left over, well, if we don't spend that money, whoever is the partner at that facility is kind of on the hook for that. And expanding on that, in track 2, where you're taking some of the payments prospectively, essentially all those providers would be taking a pay cut if we're not able to utilize those funds to pay them from. So could you expand a little bit on that, or is it left vague for a reason? Do you know if we got to the end of the year and say we completed all the activities that we wanted to, but there was $200,000 left over? In our situation, what would you suggest that a practice like one of SERPA's does?
Absolutely. So a couple comments. One comment is we're going to talk about return on investment strategies here in just a bit. So I want to make sure we definitely focus on those slides when we get to them. Let me make sure I clarify what I said. So the CMS money is typically not used for physician compensation unless the physician is conducting CPC plus transformational activities, which there is a slew to choose from. And we haven't gotten to those yet either. So one strategy that Summit basically took was we don't really want to incur a whole lot of extra expenses with this program because there's so many things that we do well. It sounds cocky, but at the end of the day, there's a lot of good transformational activities already taking place. So our strategy was that we came in and said, look, at the end of the day, let's say there's a medical assistant, and just for giggles, let's say salary, wages, and benefits of $40,000. So that certified medical assistant is conducting various CPC plus activities like pre-visit planning. She's using the teach-back method. She is the one engaging the patients in their blood pressure logs. So therefore, because she is conducting all these CPC plus activities, all $40,000 can be used to cover her compensation. So I don't know how your doctor's compensation pool works, but our physicians here are basically eat what you kill. You go out and you see your patients and you cover your overhead, and whatever's left over goes into compensation, right? So what would happen is that $40,000 that is paid for CMS monies that the physicians had used to pay for right? That's now paid for by CPC Plus. Therefore, there's $40,000 left over in the pool that would not have been there. And that $40,000 would then go into provider compensation. So for us, it's more like an indirect compensation. So there's that piece. But I want to make sure I clarify that the CMS can be used for physician compensation for completing activities that are CPC Plus. So if you're, another activity is home visits. And right now, we have a few providers that do home visits. So we could track the hours that provider incurs and pay their compensation through for the time that they spend doing home visits if we chose to do that. But we have found that taking the care management fee and using it to cover the expenses of existing staff who are already completing CPC Plus activities results in indirect additional compensation to the providers. Does that make sense?
Yep, that makes sense.
It's hard for me to, and the reason I'm asking that, I usually don't ask that, it's just I don't see you. I can tell people are following me, so, but definitely that's how our physicians have increased compensation to the care management fee. Now, we'll touch on the bonus here next. The bonus is pure compensation for all of our providers, which is the performance-based incentive payment. So that piece, there are no requirements for how it's used. There's no reporting of it. So that's all going to go to our providers for compensation.
But now we won't get that because we're an ACO under Medicare Shared Savings, right? If your clinic participates in that.
I cannot answer that question, but let me write that down and shoot you an answer.
Because that's how it was explained to us that if you are an ACO, you will not receive. Matter of fact, it's on page 29 of the application. It says primary care practices that are also participating in shared saving program ACOs will not receive the PVIP.
Well, there you go. So thank you for pointing that out, Jillian. Because we're not an ACO, I've not focused on a lot of those answers. So do any of your, I guess all your sites are part of the ACO, right?
Right. Those that are here in the room, yes, they are all part of the ACO, yes. Okay.
Well then, how about I just keep moving forward because I don't want to talk about stuff that you're not eligible for.
Yeah, I think that's a great idea. One quick question, a clarification question. As I was reading through this, to me it seemed like the chronic care management fee we cannot bill for, and if another clinic does bill for it, they get to keep it, and we get to pay, we get to deduct it from one of our payments.
That's true.
That's how you heard it also, right?
Yeah, so in a nutshell, for chronic care CPT codes, when CMS goes back and looks at which providers, given the plurality of care, the chronic disease management codes are included in that. So they're included in how a patient's attributed. But once the patient's attributed, my CPC Plus site can't bill the chronic care disease codes because it's kind of double dipping, if you will. We're getting a care management fee to have longitudinal care of the patient, and so therefore we forfeit that chronic care CPT code. So the way the Summit works is our patients are all assigned a PCP regardless. I mean, they don't have an appointment unless they're assigned a PCP in our sites, and so we establish that PCP relationship immediately. And so we don't really have a challenge with a patient jumping from one PCP who might be CPC Plus to another non-CPC doctor who's charging the chronic care management.
So you haven't had any CCM payments debited from your quarterly payment at all?
We did, but that is, and if we would bill the chronic care CPT codes, that would result in a debit. Most of our debits have resulted in patients passing away or patients who have moved out of the traditional Medicare world and gone to a Medicare Advantage plan. And the way that works, since you kind of brought that up, let me give you a quick little lowdown on how the debits work. So what would happen is when CMS goes in and builds the attribution list for a particular quarter, say Q1 of 2017, they're going to go look at all the eligible patients and the plurality of care, as we talked about, that those patients are assigned to that attribution list on January 1st, 2017. And so we get paid for 3 months worth of care management fees. But let's say that patient, maybe passed away January 31st. So in a subsequent list, that patient will be listed as deceased, and there'll be a take-back. I call them take-backs, but you could call them a debit if you want to. But CMS would take back 2 months of that care management fee because the patient was obviously just alive in January, and then we obviously didn't provide care for that patient in February and March. So that portion of the care management fee for that patient would be recouped or taken back in a subsequent payment. Have you ever done billing? It's all about the recoupments. It's very similar to physician billing piece.
Scott, is there not, though, at the same time that if somebody comes into this program in April 15th of 2000, whatever, 17 or 18, they aren't actually put in for us to get paid that fee until January of the following year?
So if that patient has had an established relationship with, make sure I understand what you're asking. Are you asking if the patient has been an established patient at a practice for a while, then they become Medicare eligible, and they choose traditional Medicare, then in fact, yes, the day that they choose Medicare, they would become eligible for CPC Plus because that PCP has provided the plurality of care for the last couple years. And so if they're new to Medicare, then that patient would be assigned immediately to that CPC Plus provider. Is that what you're asking?
Yeah, I think that the other question, of course, would be that wouldn't apply if they moved in. If they moved from Hastings to Lincoln, they wouldn't have been seen by the Lincoln physician who was taking care of them now, so they wouldn't then come into that system. They'd still be ascribed or attributed to the Hastings physician.
Yes, sir, that's correct. That's exactly right. So, and again, how I kind of explain that to providers is, in my example, the patient that passed away January 31st, we get that recoup, and so there's no offset to that. But let's say in my example, that patient January 31st decides to goes to a doctor in Omaha for some reason. So because that they had an established relationship with you all for a number of years, so that patient will still appear on your attribution list for most likely a year is what we kind of averaged out. We'll still be getting payments for that patient, although they've gone somewhere else. And those kind of patients will offset the expense of the new patients coming into your practice who've not been attributed yet.
How does CMS know to attribute somebody who's been at your practice under another payer and then signs up for traditional Medicare?
When the patient completes their paperwork to go on Medicare, they list who they've had their PC, who's been their PCP for a while, and they use that application.
Okay, there's no more questions in here, so you can go on now, Scott.
Well, I'm sorry you don't get the bonus, but I'm happy you're part of an ACO, so you're doing very well. So we will flip over then to the last two pieces of reporting. They seem kind of minuscule, but they're actually very important, and one of them is the provider roster. Again, the CMS will tell you that they attribute patients to your practice at the practice level. But at the end of the day, what they really do is they look at all the NPI numbers of all the providers who practice at that address, and then they look and see which one of those providers have given the plurality of care to those patients. So they say it's the practice, but in reality, it's really the provider. And so when you bring on a new provider or if a provider terminates, it's very important to go into the portal and make sure that we maintain an accurate list of the providers and that we have their NPI numbers in there, because CMS will use that to establish plurality of care and thus build the attribution list. And then the other type of reporting is regional. Again, I mentioned we're in the Tennessee region. I have found some of the reporting I've had to do for Tennessee to be duplicative in nature to what I'm already giving CMS. But at the end of the day, it's nice to have a whole lot of resources, and I can call, if I have any question, I can call multiple folks who can help me get an answer. So that finishes the reporting piece. Do you want me to stop for a second, Jolene? Are there any other questions at this time?
I don't see any questions in here, so continue on.
So let's move on to the return on investment, and we kind of touched on this earlier, but I kind of tell folks, you know, at the end of the day, the return on investment is in the eyes of the beholder, and it really just depends on what the motivation, the intention of the organization is, and how much autonomy they have. And as I mentioned earlier with Summit, our goal was not to increase expenses, but rather to use the care management fee to pay for existing expenses. I've come across other CPC Plus practices where the providers have said, hey, you know what, Scott, I've wanted to be in telemedicine for years, and I'm a Track 2 site, and therefore I can use some of this money to pay for telemedicine, and at the end of the day, I'm fine if CMS pays 50% of it and I pay the other 50% because I just have this passion for telemedicine. So you kind of have the different mindsets on a whole range, and wherever you land, it kind of depends on your practice address, the people who practice medicine there, really. But I did want to kind of share with you, you can either, you could probably at the end of the day increase compensation, as I illustrated with Summit, or you could embark on new staff, new activities, and have CMS pay a portion of it. It kind of depends on what you want to do. A couple of factors that I've used, again, I mentioned I'm a CPA, and so I've done physician billing for years and can't get away from it, and just used a lot of my background to help, to work with my CFO here at Summit to kind of look at various factors in determining a return on investment. And one item that I would encourage you all to look at heavily is using those billing reports and going back and determining what is your true traditional Medicare panel, and making sure that you could definitely come up with an estimate. You have the care management fees by tier in previous slides, so you could pretty much determine what you think your pickup is going to be from an annualized care management fee. So I would definitely use the reports that you have available to determine what you think that money is going to be for your ROI. Again, we alluded to the HCC coding. Another ROI factor is going to be how much attention has been paid to that over the years. Another piece is your ADT fees. Again, we need that bonus. We're looking for that bonus, and utilization is tied to that bonus. You guys won't have that that option, but if we have difficult ADT feeds that break and we can't really do the care coordination as we'd like to do it, then that becomes a problem and impacts our financials. I also mentioned earlier, our EMR did not have the ECQM capabilities, and we're still struggling with it. And so again, that quality measure reporting is important for the reporting, but also because we have bonuses tied to that. And you can go through the rest of
Scott, this is Jolie. On the ECQM reporting, is that on all patients or just Medicare patients?
Excellent question. It is, an ECQM is designed to report a measure for all patients in your EMR regardless of the payer. And so that's why it took me, I'm a little slow, and it took me a while to kind of get this. But at the end of the day, CPC Plus is transformation for all patients in your practice, not just a particular payer. And to your point, Jolene, we at Summit were thinking, oh, you know, we're going to have to do X, Y, and Z for our traditional Medicare patients. Then we learned, oh, wait a minute, no, we're going to have to do X, Y, and Z for all of our patients in our practice. Well, if you think about it, an ECQM goes along with that theme of reporting quality for all patients in your practice regardless of payer. That's the way that the ECQM functions.
Thank you.
Great question. So anyway, so we talked about the ROI variables. Now the staffing, Jolene asked me to touch base on staffing, and I've kind of alluded to this already. I'll use Summit Medical Group as a case study. So you'll see on this slide, I've already talked about this. These were the two goals that we had, was to cover existing expenses as much as possible. Our care coordination and our risk adjustment We have a quality department and a health education department that are all in our central office. And so we did have to increase some expenses in our central office to make sure that we were able to conduct these activities for all patients and all the practices. So, but as we considered CPC Plus, we looked at our existing infrastructure, which we have episodic care coordination and we have longitudinal care coordination already in place. We also had a quality process where we have quality gap reports. I'm sure you all do too. We have a whole annual wellness visit process where we have wellness visit reports that show patients who have not been into the office within a certain time period. And a lot of our quality is based on bringing those patients in for their annual visits and then closing quality gaps while the patient's there in the suite. And often now we do a lot of pre-visit planning. I mentioned that earlier with my risk adjustment folks. We also have our MAs do pre-visit planning where they look at a quality dashboard a couple of days before the patient presents and identifies the outstanding care gap. And then, unfortunately, we do it on paper. I'm embarrassed to say that, but we do. We mark the different quality gaps on a piece of paper, and then doctor has that as they go in to see the patient, and that way the doctor doesn't have to hunt and peck through the EMR. They have that piece of paper there, and during that wellness visit, they talk about the colorectal screening that's outstanding, or the breast screening that's outstanding, or they talk about the A1C that's still out of control, and it makes the visit a lot more efficient. So again, we considered that in how well would we meet these ECQM thresholds. Then we felt that we had a good process in place. I already talked about the risk adjustment staff, and I alluded to our health education department. One of these CPC Plus strategies, which we already meet, is having health education group classes for a number of our patients. So we have registered dietitians that conduct those classes. We also do shared medical appointments, which I'm a huge fan of. I don't know if y'all are familiar with those, but basically what happens is in a 2-hour period, a provider meets with about 15 patients in one room, and there's an MA present, and then there's a health educator present, and the physician is literally seeing the 15 patients in this 2-hour period. At the same time, the health educator is instructing and having peer discussions on the chronic disease. And so the takeaway is that the physician gets to bill 15 different E&M codes because each one of those patients represent an encounter, and the patients have an exorbitant amount of peer support and obviously have a lot of education. And so we already do that, and that shared medical appointments were already a CPC Plus initiative. And so that's one of the reasons why we. And then not only did we look at our central office, but we also looked at our practices to determine what tasks were already in place. And you'll see I mentioned the pre-visit planning. We use the teach-back method. A lot of our sites don't, but it's like an hour video that the MAs look at, and then they can engage in it. So we thought, we could do that and not incur a lot of expense. The self-management tools I talked about, the home visits. I'm very proud of our callback program here at Summit. They do an excellent job. The MAs will call back the patients and talk to them with all results, regardless of whether they're positive or negative. We do a pretty good job tracking our outstanding referrals. We have daily huddles, which is a part of the NCQA PCMH program anyway, so we're already doing it. And we have same-day appointments and extended hours. So and these were the activities I wanted to mention to y'all earlier. You might recall I talked about the 5 functions, and each function has transformational goals, and then each goal has these activities, and here's a list of activities. Hopefully that kind of ties the whole picture together for y'all on how CPC Plus functions. And before I go to the application process, are there any other questions?
I don't see any here.
Finally, application process, and I don't know, Jillian, how much you all really want to get into. I went and got a couple of links here to checklists that Summit Medical Group used for their applications, and the checklists were very helpful. So you have that link. There's another link for the open forums. If you all were not planning on attending them, I strongly encourage you to attend those open forums because they will address questions that people have in the application process, and you guys already have a strong understanding that you have to do one application per address. Some immediate tasks, if you have, what I would recommend is with the application process, definitely complete tasks that you're dependent on other people to complete. I have found that the tasks that I can do those last minute if I have to. It's really hard to get letters from my EMR vendor about what certification they are if I wait to the last minute. You all will have to have a letter from your ACO leadership talking about how you support the CPC Plus and how you'll separate the funds. The payer mix reports will be important on the application. CMS is going to want to know what percentage of your patients are Medicare, traditional, Medicare Advantage, your Medicaid, and so forth. So we have a pretty large organization, and I wanted to get my reports quickly, so I had them. So I'd recommend getting those, but it takes a while to get those reports. If you had your sites have been parts of other tax ID numbers in the past, if you have to hunt and peck and find that, I suggest you do it now. And then for us, again, it's just based on our experience, we've had a challenge with our EMR. And so in retrospect, I would have gotten my cert letters and confirming ECQM functionality before now. There's, I guess in a nutshell, that's it. Hope I haven't talked your ear off. If it's been therapeutic for me, I apologize if it's been too much information. But I wanted to make sure you had as much information as you needed to make a good decision.
Are there any questions?
Jolene, I don't know if this is an appropriate question for now, but the part that's confused me is, let's say all the clinics apply, okay? And let's say they all got quote unquote accepted, okay? Then there's a process of picking which group you're in.
Oh, are you talking about the I'm sorry, the control group and the other group? CMS does that.
No, I understand that, but what I don't quite understand is the difference in reimbursement between the two groups.
What I have heard up through now, and what I have, is that if you are in the control group, you don't have to do any of this work, but you don't get paid any of this money either. You get
There's a
$5,000?
small fee, I think, Rick, you're right. I don't know what it is, but there's a small fee for being in the control group, which is kind of, because they still want you to do some reporting, because they're trying to compare you versus the group.
So would this gentleman know?
What do you know about the control group versus the other group?
Yeah, I'm not familiar with the terms, actually. I could go look on and do some research and shoot you what I find, Jolene. I'm happy to do that. But I'm not familiar with the control group versus a
Yeah, that's what they're
loan.
That's in the CPC, the second two, is that they're going to do a control versus a actual intervention group. Anyway, that's what has been said.
Jolene, Brian, this is my concern, though, is all of our clinics are already way ahead of what a control group would be, because we're not going to discontinue doing all of these processes we have in place. My question would be to find out if we could, if they assign us as a control group, if we can opt out.
Yes, you can. I will make a comment just based on well, let me say this, based on my experience, I can confirm the control group requirement, but I know our agreements have a 90-day out anyway, and that was how I some of my providers had a little bit of a challenge getting into this, and at the end of the day, it was like, look, you can get out in 90 days, and once we got the letter being accepted, and then the letter tells us what assignment we've been given, which in this case was a track 1, we never really had to sign the contract. We just got a letter, and then later came the contract, and then we signed the contract. So I would venture to say, they will probably give you all letters saying what you've been assigned, and then they'll probably submit a contract, and if you don't want to do it, then you don't have to sign the contract.
I just found in the application, it's on page 8 and 9, it talks about practices assigned to the control group will have the opportunity to enter a control practice specific participation agreement, and you get the $5,000 for the time spent on evaluation. And then in addition, CMS will propose in rulemaking in 2017 to establish a new MIPS improvement activity that may give credit to participation in the CPC Plus control group with an active control practice specific participation agreement. Control practices will continue to receive their usual payment under the Medicare physician fee schedule and will not be required to implement the CPC Plus care delivery practice changes, and will not receive CPC Plus payments, and will not participate in the CPC Plus learning communities. Additionally, they will not be considered participants in the advanced APM through participation in the CPC Plus control group, but may otherwise be an advanced APM participant through participation in other CMS models. So that is we're really concerned about our ACO being split up into intervention and control group.
Sure, I would be too. But it sounds like what you just read, Jolene, is that at the end of the day, they're going to tell you what you've been assigned, and then there's a contract they'll send you, and if you don't like what you've been assigned, I just wouldn't sign the contract.
Okay.
I know with Summit at the time that I wasn't here when they actually did the application, but when they did the application, they applied for Track 2. Actually, in Tennessee, there's very few Track 2 assigned, and so that was part of the reasons why there was discussion of, do we even want to do a Track 1? And those were healthy questions. We just had to dig in and find out what was the benefit of being a Track 1. Sounds like in this case, you guys know what a control group benefit would be. And so, yeah, it sounds like you have the opportunity to get out or not even participate if you don't want to.
Okay.
Jolene, what were you reading from?
I am reading from, it is called Request for Application version 3.3. I will be putting all these resources out. I'll probably do a CPC Plus data folder or folder out on Basecamp. Oh, this is already there. I already did it.
There's a folder there, and I scanned the one about the, thank you, implementation guide.
Okay, so it's out and it's under all SERPA ACO, or is it's under all SERPA ACO CPC?
Docs and files.
It's on docs and files.
And the CPC Plus.
And the folder is CPC Plus, so it's under all SERPA ACO, docs and files, CPC Plus. And we'll be adding other things as we go. We'll add, go ahead.
Sorry. I was just going to ask Scott if you knew any CPC or risk training courses for providers.
Actually, our organization offers those. So those are the ones I'm most familiar with, honestly, because I'm kind of narcissistic and I don't get out much. So I'm sure there's probably other ones. I think the challenge that I have seen in places where I worked before coming to Summit is that the HCC coding, although the providers need to obviously know it, there's no question about it, the challenge I've seen is having people who are coders who understand the diagnosis and the disease burden process, and there's really no coder training that I've seen out there. Usually our coders are procedural coders that have come in and they've had to add to what they've learned to look at a whole medical record and show diagnoses that represent the disease burden. So I think a physician obviously is going to get that much more quickly than our coders would. And so I certainly could look and see, but I do know that Summit Strategic Solutions does those courses.
Any other questions for Scott and Melissa? If not, we want to thank you for your time and for sharing everything you have learned and everything you have done. We really appreciate it. Thank you very much.
It's my pleasure. It's good talking to you all, and I wish you the best of luck.
Thank you.
Thank you.
Y'all take care.
I'm going to take back the presentation. We have here today, we have Jason and Chris Wright from Group Source. They're going to talk a little bit about, we have gone into a group purchasing organization. I don't know if you have slides or if you're just going to talk.
We can get into slides if you want to, but I think we can.
Okay, because we have people online, and so I didn't know what will be best for you. That's why I'm asking that.
Yeah, we'll try it without slides.
Okay. Okay.
Do you all need a break?
Anybody need a break? Okay.
You guys aren't wore out yet?
Yeah, we're not wore out yet.
Yeah, but
And then we'll talk. We'll let you guys talk, and then we'll talk a little bit more after this about CPC Plus and some of the handouts I have for you.
Great. Well, my name's Jason Andrews, and that's Chris Wright, and we're with Group Source, and I'll kind of explain to you kind of what. I think it might be one short. Sorry, I'll get you one. I'll explain to you kind of who we are and what we do really quickly, and then answer any questions. And so we met Jolene at the National ACO conference in Washington, D.C. in April. And we were there because ACOs present a great opportunity for us to aggregate spend and bring some visibility to organizations like yours on the spend side of things. And so what group purchasing organizations do in the non-hospital environment, same thing they do in the hospital environment, but there's really not a lot of companies that focus in the non-hospital environment. What we do is we ensure that you are connected to the contracts that you are eligible for. So for all the things that you buy from a med-surg standpoint, and there are some things outside of med-surg too, but for all the things that you buy, you're connected to the contracts that you should be, and so that's the first and foremost. And we're doing that as we speak for you within your agreement with McKesson. So we're in the process of doing that now. Now, that's at an individual clinic level. That has been going on, and we've been doing that for 20 years. What SERPA gives us the ability to do is to take the spend of each clinic, combine it together to access greater discount tiers. Okay? So one of the things that we do behind the scenes kind of always is take a look, and we get reporting of everything that you order from McKesson on a monthly basis. And we analyze that spend and say, okay, has their spending changed at all? Are there new things that they're buying and an opportunity connected to a contract to get a discount? That's the first question we ask. Then the second is, based on what they're buying, are there additional contracting discount tiers that can be accessible? We ask that question in two levels, at the SERPA level and also at the clinic level. And so some of those aggregation discount tiers are volume-based, where you combine the volume of all the group, access a greater discount. Some are compliance-based, 80% compliance or whatever the case may be. In that case, we can look at that individually. Maybe some are 80% compliant on contrast media with Bracco, and some are with GE, and we can that out and do the discounting there. So all this to say is we're sort of that partner that's behind the scenes, looking at all those things to connect you to the contracts that you're eligible for and getting you the greatest discounts that you're eligible for organizationally. That's first and foremost. Then beyond that, we've got programs that are specific for non-acute facilities. So things like, I think we can help you, and one of the things we talked about is trying to understand what you're doing with your vaccines, and is there opportunity for additional transactional value there. And so what we do is we'll take all of your spend data and take a look at it, distill it all down, and come back to you all with some recommendations saying, hey, this one might make sense to go through distribution. This one can be direct. Hey, here's some areas over here. And then you can pick and choose based on what's best for you. So we won't require you to do anything. What we do is we take a look at that, and then we provide suggestions. And so we take something that individually that all your clinics are buying, we distill that down into some data and then say, here are maybe some standardization opportunities, here's where we see some savings opportunities, and then you all make the decisions on what's best for your organization moving forward. So we're just that, we play that role. And then outside of med-surg and vaccines and pharma, we do that with office supplies, we do it with credit card processing. Is Plum Creek here? Okay, so they send in an analysis for credit card processing. We just got that back, and it's an 8% savings. And so that's becoming a bigger and bigger piece of spend at the clinic level, is what's going through credit cards, or with any sort of time you're swiping, it's that. And then if you're getting paid by insurance companies with P cards and that sort of thing, there's transaction costs to that. So those are greater spend areas, and we've got a program for that as well. And anything that we will do for you will be a detailed analysis that shows exactly what you're paying today compared to exactly what you'd pay under the program with no obligation. So you won't say, hey, trust us, you're going to save money. You'll see exactly what it is on exactly the things you're buying today. If it makes sense, you can decide to do it. If it doesn't, you don't, and there's no obligation in that regard. So it's really incumbent upon the program to show you the value, and if it's there, then you make the decision that way, and if it's not, then that's fine too. Done a lot of talking.
Well, it's a question that I don't know that we've discussed or have come up with some recommendation, but, for example, I think I sent one in from, I can't remember, it was Pfizer, I don't even remember who it was, but somebody.
Yep.
And or Santa Fe Pasteur with vaccines, or, Prolita, our new great, spending thing we do. So are we supposed to, Jolene, identify, say, 4 or 5 big dollar things and send them to you, and then do you guys aggregate them? Because I heard you say there's a SERPA aggregation. If we meet some kind of a goal for SERPA, could be one level of discount, or you might have a discount opportunity in your individual clinic. So Jolene, what is it we're supposed to do?
That's what I asked these guys here to tell me, so that,
The short answer is yes, and there's a much long, here's the thing, when you look at vaccines, you go to the 3 big players, Merck, Sanofi, GSK, a little bit of Pfizer. We can look at that spend for everybody and say, here's, when you put everybody together, here's what it looks like. And you go, maybe GSK, it makes sense for you guys to buy distributed from McKesson. Maybe Merck and Sanofi, you keep buying direct, and here's what that pricing looks like. So we'll take the data from all of you guys. Pfizer, same thing. It may be that with our contract portfolio, maybe it's about the same, or maybe a couple % more to buy it through distribution through McKesson, but you say, well, we cut an entire vendor out of our portfolio, and we get all that back off of savings, because the 8 times a year we buy it, you have costs associated with cutting that check, and the time to order it, and the time to check it in. So what if you paid, it was nearly the same cost, and you bought it through distribution, and it just comes with all your other stuff. So we can kind of show you those things and let you make your decision on your own. But so we're happy to do that.
The answer is really, what to do is it depends. And so what our job is to get the data, and we've got a non-disclosure agreement in place. So this data that you'll send us doesn't go anywhere. So we've got a team that sort of analyzes this and will present you back opportunities. And some of those opportunities may be, what is it to continue order direct? Does it make sense to have some of these go through distribution? And we just present the options back to you and dollarize those options. So, how much of it's savings, or, maybe it's 1 point more, but there might be worth it inconvenience. And we present you those options at a group level, and then where it might make sense individually. And then if there are 1 or 2 groups that are ordering some things that no one else is, okay, what if those were what everybody else was ordering? Is there an opportunity to standardize, and can there be value there? Again, no obligation to do that, but what we do is we take all those pieces and, kind of a team that does it and 20 years of experience doing it, and then roll that back out to you all and distill it out in a format that can make sense for you to make decisions, because you all are busy. Like I say, our stuff is very easy compared to CPC Plus and all the things that you all are dealing with. And so we're sort of that arm and that can take that, analyze it, and bring it back to you in a way that it simplifies it for you to make decision making. And in short, the decision may be what we're doing right now is the best thing to be doing. That might be the answer. We don't know.
So what is your turnaround time if we send you something like I sent that to you? So then what, do you guys send it back to me, or you send it back to who sent it to me, or?
The turnaround time for something like a credit card processing or office supplies, things like that, 5 to 10 days. You know, we can turn that around pretty quickly. The vaccines is going to be a bigger piece, and for that we would want to have all the pieces in order to put so we kind of have one piece. And the issue with that is, we'll want to send it to you. So the first question is that something you all want to tackle as a group or individually? If it is, then we can get that out to you all on what we need, and because it's net of all discounts and actual price paid in a pretty short period of time, because prices can fluctuate quite a bit. So we'd want kind of 60 or 90 days and exactly what you paid, and the volume of all those things and where you're getting them from currently.
Really the best way for you guys to give us that data is just to scan an email or run copies of invoices, because it has the NDC numbers. It has whether you're buying a 10-dose vial or pre-filled syringes. If all that data is there, we have people that will turn paper into a spreadsheet. So the easiest thing for you guys to do is have slap it on a scanner and scan and email it either to me or Jolene or who however you want to do it, and then let us compile that data and then come regurgitate it back to you, probably in a conference call and a webinar, and say, what, here's what we found. So,
And that's kind of what you did, wasn't it, Dave? You sent
he just ran copies of his.
Yeah, well, you saved me a lot of time, because I was doing all that stupid spreadsheet when all I really need to do is send you the.
That's all. And here's the thing: if folks want to look at
mine too, I think. Probably.
If you want to look at office supplies, that's it's the same thing. Just put a couple months worth of invoices in it and just scan them and email them to us. We'll turn your paper invoices from Staples or the local guy or Office Depot or where Amazon, wherever you're ordering them. We will turn those into a spreadsheet, apples to apples, and then be able to give it back to you. Craig, your credit card processing, that is a very clean and neat transaction. I think I forwarded you the email back from our guy. Of all the programs he's seen, and he sees hundreds a year in the analysis we do, he said they had one of the most aggressive. We still found 8.2% savings, and his effective rate is going to be below 2%. But you look at it, you go, I've been in a lot in the last 4 or 5 months that are 20%, 20, 25, and for him to be 8, you go, wow, God, it's almost disappointing. But you go, hey, guess what? They've really paid really close attention. They've done a really good job. And because our program has millions and millions in spend, still 8.2% savings. So you look and you go, it's things like that. We'd love to see him double that, but you did a good job.
Okay, I'll take double.
Okay, go for it. You're not going to fight him, are you?
It does, but somebody is really paying close attention to what they're paying for their credit card processing.
So when you think of us, ideally what I would want you to think about, so you've got partners as it relates to, really around the revenue generation side. I mean, it's coding or collections, all the things about bringing more in. For the things that are the things that you spend money on, non-labor spend, I want you to think of us as a partner in that. Feel free to call us with anything. If you're looking at, hey, I want to take a look at lending services or magazine subscriptions. I mean, we've got a contract. We can help you potentially in every area of non-labor spend that you have. And so that's really our role. And so there are big things there, med-surg and office and vaccines. Those are big ones, but there are smaller ones too, and we can help you there. And so that's the kind of the non-sexy part of it, but it's really important. I mean, the less you spend, the more you have in the practice. And so adding purchasing sophistication to that, there's a lot of things that can be done now that you can speak with one voice as a group. That brings a lot of things to bear, and our job is to help you unlock that value and to demonstrate that to you in an easy way, because you all are really busy and you got your hands full with the other stuff.
One thing that we talked about was the aggregation on medical supplies and that kind of stuff. And, an important component to that for, everybody that's on the call and in the room is kind of figuring out a go live date where everybody's going to move forward with the McKesson distribution contract, so that as the data comes back to us every month, we have a good view of what everybody's purchasing versus, well, it's only these 10 people are using the program, because then, the rising tide isn't going to raise all the boats, because some people are over here haven't migrated over yet. So that is kind of an important component, is to get that, kind of say, okay, 7/1 or, whatever that date is in your guys' mind, we're going to start everybody using McKesson, so that we can use everybody's collective leverage to make sure that the contracts are as good as they can be, and start evaluating that right away.
Is there a go live on that?
No.
Not yet.
We asked for paperwork to be returned by June 9th, I think. Yeah. So everything in.
You resent an e-fax. I couldn't open that. I mean, the e-fax comes through, but it's blank. So did you bring me a hard copy of your signed document? You're the man.
Look at that.
You're
Tell me what 20% off a plate.
Yeah.
I keep saying it to that.
The switching to McKesson, is that something that we already decided,
No
or
problem.
like?
But it's probably, Karen probably had that.
Yeah, we don't.
Yeah, it's probably back to Kansas City Warriors. So.
Yeah. The McKesson McKesson contract has been signed, that we can go that way, but it is, you don't have to go with McKesson. If you have somebody else you like, we never dictate, but if it's a better rate, we would, encourage you to. So, does that make sense? So,
Is anyone from Butler Clinic here?
no.
What about Lincoln Family Medical Group?
That's me.
I don't have your paperwork yet.
Did you just send it in to me?
No.
And Lincoln
For
Family
Lincoln,
Wellness.
for Group Source, okay.
Lincoln Family Wellness, are they here?
I'm here.
Okay, we don't have her paper.
Did I send that in to you today? I sent in somebody's today. I don't know who I sent in today.
Yeah, I turned it in right away.
I think it was Lincoln Family Wellness, that's right.
Okay.
Yes.
All right.
Yeah. Yeah.
We're pretty good.
Yes, thank you all for
We had Butler
being very
and Valley Practice Associates and the two in Lincoln. So I think we're going to be good. We'll find where yours is at and